endometriosis is something very difficult. We have sometimes fibroids. Not all fibroids, or not that all endometriosis needs to be treated surgically. Sometimes medications itself can work well for them. Of course, it is quite big. It's causing a lot of physical problems for them, or it is hindering the passage of the sperms or the eggs or the fertilization or implantation. Then we have to treat. Coming to these fibroids, sometimes they could be just sitting inside the cavity. We call them submucosal fibroid. They have to certainly be treated irrespective of the size.
Mm-hmm.
Why I'm saying irrespective of the size? Because if there's a fibroid of 4 or 5 centimeters sitting outside the uterus, it's not going to hinder our pregnancy in any way. Then we don't have to jump into a surgery. But if it's there inside the muscular area, which we call as the myometrial region, and there also I have no problem. But then if it is altering my cavity region where the baby is going to come and sit, then I have to operate. So we have to use a lot of technology. I'm a robotic surgeon myself, so I feel it has definitely helped. I've been a laparoscopic surgeon for more than a decade or so, only laparoscopic surgeon. And of course, I do continue doing my laparoscopic surgeries. Of lately, I would say 6-7 years, I've been using a robot, and helped me relieve quite a few patients, especially when it comes to endometriosis and fibroid removal. Works very well in such a way, it gives patients faster recovery. They can plan their pregnancies much earlier. The results are much better. Recurrences are much lesser, and their conception rates have become very high.
Very nice.
So, and I think that's working very well for us.
So structurally, you say there could be problems with the vagina, with the uterus, ovaries. What about the tubes?
Tubes also, because when I was talking initially about the scans, unless you have a pathology, we will not pick it on ultrasound.
Mm-hmm.
So that means if there's a fluid collected in the tube, only then I pick it. We call it as an hydrosalping. Sometimes there could be a pus collected in that. So only then we pick it. Generally, we don't jump and do a tubal test in the beginning. We say you can try naturally depending on how long they have not conceived, the age of patient, the hormonal factors, the semen analysis we try to see. Now you've done your basic treatment, or you've given them some tablets, injections, 1 or 2 cycles, you don't conceive, then we definitely evaluate the tubes. We can do simple things like HSG, which is a hysterosalpingograph we do, where we take an X-ray, we put a dye, which gets picked up, is the tube open or not. We also do a laparoscopy. Sometimes we see a cyst and we have something else. So we use it as a combined procedure. Through a laparoscopy, we go inside the abdomen of the patient. Then we see if the tube's all right or not. Advantage with laparoscopy is you can try and treat the patient simultaneously. Either you can do a cannulation open, or if it's stuck somewhere else, you can release these adhesions. So they help. So all these things can definitely be treated. So yeah.
So we divided into like 3 different sections now.
Yes.
Parts of where it can get affected, and the situation itself, like environmental factors, psychological factors, and physical structural factors we have.
Environmental factors, so much stress. Sometimes, I think just a little reassurance from every doctor to their fertility patients solved quite a lot of it, because they're like, okay, we have this doctor. Any doctor for that matter. I'm not just saying me and I'm talking to my patients. Any doctor, once they are sure, it doesn't have to be fertility. I think it could be a cardiac issue, neuro issue, anything.
Absolutely.
So you just reassure a patient, and you see that the patient themselves are recovering much happier. I think that's what brings their stress level, and that's how we have good conceptions also.
Nice. So those 2 factors, like environmental and psychological factors, seem to be common to both men and women.
Definitely.
Now, the structural things we spoke about in women. What about males?
Yes, now varicocele is something that we are seeing where they have tortuous blood vessels in the scrotum area, and this is inhibiting the blood supply. So there's no proper blood supply happening. So this is why we are seeing the sperm qualities reduce. And over a long duration of time, we are seeing that the morphology of the sperms are also becoming very bad. And not just the males, I think sometimes, or quite a few times, the females are also competing with the male when it comes to smoking, alcohol. It's like the peer pressure. I'm not sure what's happening. That lifestyle's changing. And these factors like smoking, alcohol, nicotine, excretion, drugs, everything, all the recreation drugs which we use, everything is getting a lot of effect on the sperms and the eggs as well.
Mhm.
So while we talk to the patients, we take all these histories, from tobacco chewing to a lot of things. I've had patients with all kinds of habits. So we'll have to start working on that itself. So that also becomes a problem. Not all varicoceles, like I mentioned, the tortuous vessels have to be treated. We have to get a scan done again. What is the grading? Does it need a surgery or not? So to make sure that the blood flow is good, and that is how you have a better quality. Sometimes either a childhood trauma or trauma even at later phase leads into obstruction. So the sperms are not coming out. Unless you do a test, you will not know if the sperms are not there, because a male says he's ejaculating. So nobody is seeing is there a sperm or not unless you put it under a microscope. So that is how we see that there are no sperms. So we call this as an obstructive disorder. So we'll have to do sometimes a surgery to connect that. If it fails, then we do something called TISA-PISA, where we pick up these sperms from the testicular region. Then we have no choice. We have to do an IVF for the partner, and that is how we pick up one egg, one sperm, fertilize. Or we have not a good quality of sperms, but you have. So even if it's like less than 10 million, or you can still try an IUI, but then anything less than 1 million, 5 million, better is to go for an IVF or an ICSI. You pick up sperms. If there are decent number of good sperms that we have, we leave them in a dish. The eggs and the sperms are left together to see fertilization happens. We call this as an IVF, in vitro fertilization. Now we have very less number of eggs and very less number of sperms, or we've done a procedure, we've picked up sperms from the testis, then we do something called an ICSI, that is cytoplasmic sperm injections, where we take one sperm and put it inside the egg and fertilize it. So the technology is definitely there. It is to what extent a couple wants. And I feel in infertility, you need to have a lot of patience. Because we doctors can only play gods. They cannot become gods. So you have a inhibition there. You can work to a little smaller extent, help them. We try to bypass the nature. We were talking about the male factors. Quite a lot of times, not so good sperms, be it the quality, quantity, and abnormalities which is there in the sperm, especially when these patients do conceive. We're seeing a DNA fragmentation, we call, that can also be genetic. If it's a male baby, it can get passed on as well. Either a very poor egg, we forcefully inject and fertilize them, they also end up having a lot of abnormalities, or they don't end up conceiving, or the implantation doesn't happen, or even when they conceive, they abort. And again, the technology is so much developed that we send these product of conception for testing. We have picked up chromosomal abnormalities in these babies. So we assure the couple, look, it was not a good baby. It was not a viable pregnancy. So we can plan. So in fertility, the technology has become so good. We do something called as PGTA. So we do the pre-genetic testing in these embryos, and very helpful for patients who have a lot of familial disorders or some abnormality. So we can pick up these embryos, try to do testing, and if it's a good embryo, we put it back into the uterus. If it's not good, we don't do the transfer. So I think the couple also have come to that level of understanding. I think patients from the doctor's side and the patients from the couple side to understand what is the problem is something very, very important.
So once we have a diagnosis about this structural issues, either in male or female, or maybe both of them have a problem,
yes,
then you need to deal with
30%
both of
them have issues with both.
With both of them.
Yes. Yeah.
And probably there are some factors which are not correctable psychologically or environmental wise with their work culture and things like that. Yeah. What other option do they have? I'm pointing towards surrogacy or donors and things like that. Where do we stand in that?
I think we are good but not very great in this segment. When we talk about donors, we have sometimes women where egg qualities become so bad and she herself is not able to produce her own egg. Or like I said, we've done testing and we realize she's contributing to the abnormal gene and then we can't pick up her egg. Or she has a genetic disorder which she doesn't want to get passed on to the baby. Then we have no choice. We go for a oocyte donor. That's the egg donor. Luckily, in India, we have a law now. So everybody has to abide by the law. Initially, it is like, oh, this friend, she's coming, she's donating, and then we take and we do this. We, of course, have to work on the consent. But now there's a law. What is the age of the donor, be it the male or the female? So we have to go by all the regulations. You have to get your affidavit done with the lawyers, the advocates. Everything is streamlined in India as well now. So we have a law, which I'm very happy. So you get these egg donors. And if the male partner is good, so we use their sperms. Once the baby is formed, we put it back into the mother's womb. At times, we have problem with the male, where you've done a PISA, where you've picked up sperms from the testis, but you still end up having abnormal sperms and you cannot utilize it. Or we have people where they don't produce any sperms at all. Then you have no choice. Then we go for a donor sperm. So we use the lady's egg, naturally conceiving. So we take the sperm donor. We can do then we don't have to go for an IVF. So we can do simple procedures like an IUI, where the doctor injects the donor sperm, which is screened. So again, like I said, it's a law. We have ART banks, we have sperm banks, we have egg donor banks we have. So everything is authenticated, everything is checked, and everything has the regulations to be followed. So we take that, do an IUI. Now, if they have some other issue, then we end up doing, like, there is a problem, like I said, genetic factors even in the male. So these are the reasons why we pick up a donor sperm. Now, if there is a problem with both, instead of taking a donor egg, donor sperm, I always say go for an adoption. Because you're anyway choosing both the genes, something which doesn't belong to you. So better to go for an adoption, and then you're giving life to another person who is already in this world. Somebody who is not privileged to have a parent, they get a parent, and you don't have a child, you get a child. And I feel that's an easier option. But unfortunately, that's not what the world wants, not what the patients want. So they want to have the baby in their own tummy and they want to feel that pregnancy. Then you have no choice. You have to go for these things. Unfortunately, quite a few people cannot carry a pregnancy. I've had patients with very high-risk patients where we call it as a cardiomyopathy, where we tell patients you are going to die if you're going to become pregnant. So I've had quite a few of them. I've had patients whom we had to terminate pregnancy because if she continues her pregnancy any longer, we are going to lose the mother. Yeah. So we could have all these issues. So we'll have to work on those things. So if the uterus is not good, then we have to go for a surrogacy.
So we were talking about this donors, oocyte donors and sperm donors. Probably there's a bit of a misinformation. Correct me if I'm wrong. These things are anonymous, isn't it? You won't know whose sperm it is or whose egg it is.
Yes, if you're getting it from the bank, it remains anonymous, where you don't know who is the donor. But what we do, we match. So if you want a sperm donor, we take the profile of the patient who needs, we match the skin color, the hair color, hair texture, the eye color. Last week I had a couple who were like really fair, not the Indian color at all. They are Indians though. So the South Indians, typical South Indians, but really fair. And unfortunately, both the couple have green eyes. And she needs a egg donor, and they've been insisting on a lady who's going to be fair with a green eye. So we have to talk to different agents or different banks to make sure we get something that they want. So we match the profile of the lady. You need an egg donor. So we match everything from the height. We try and match as much as possible so that when the child grows over a few years, the child doesn't look something different from the couple. So you'll have to match, and these are all the basic things that we have to do. So there is like altruistic donors as well. You can get somebody who's known, but then we discourage. We discourage because it's in the family or it's a friend. Then you know you're the one who's given the egg or you have given the sperm.
Is there a law against that? Or
no, there is not. There is not. So you can do it, but then we wouldn't advise. We would say it is okay. It is okay. But then we would always encourage patients to go through the banks because it's anonymous. It is not known. So there is no question of somebody tracing back and claiming that this is my child, or you don't even have a social obligation. And this is all done legally. So no, the donor doesn't know where their sperm or the egg is going, because they don't get to meet the recipient mother or the father. And it's the same with that. So when you have somebody who's known, I think it becomes a social obligation. So that is where the problem arises. So we discourage, and it's better to go through the banks, whether it is the egg donor or the sperm donor, I think is important.
Nice. So where do we stand with the surrogacy point of view?
Surrogacy, again, it's a very rigid law in India. Initially, I think you've also heard a lot of stories where the celebrities, not across just the India, across the world, where they don't want to give up their career, or they want to look slim and fit and perfect for the screen looks, or somebody's very high aspirant woman who doesn't want to give up her career. So it was an easy option for them to go through a surrogacy. But now we have law which doesn't permit you for fancy reasons. You need to have a medical indication if you're opting for a surrogacy. That means you're renting out somebody's womb there. So you have to go through a lot of legal documents where you're meeting the advocate, the magistrate, you have to register, you have to find the right kind of a person. So where we have even the legal documents done for the surrogate, where the recipients have to do a insurance for the surrogate, they have to be looked after well, their medical insurance needs to be done, their life insurances needs to be done, their care of pregnancy until they deliver, and for almost 1 to 2 years they have to be taken care. So the law also has become very strict, where we're not just trying to help the couple, but we are also helping somebody else and making sure this surrogate also remains healthy. So that's a very long procedure, because you have to go through the legal formalities which could take anywhere from 6 months to a year. First, finding the right surrogate, getting these legal things, and the surrogate herself signing where the family also agrees. So a lot of these things, so where the surrogate needs to be cared for because the baby is there. It's like a normal pregnancy where the nutrition needs to be addressed. A lot of these things has to be done.
And how common is it?
I wouldn't say very common, because now it's not done for fancy reasons. So it's not very common. But then we do have a lot of couple where they have medical conditions where they cannot become a mother themselves. So we have conditions like cardiomyopathies, where if that lady becomes pregnant, she's not going to survive through her pregnancies. We have terminated quite a few pregnancies because everybody doesn't go through a heart scan, or they don't have symptoms for the doctors, because we can't unnecessarily keep doing a screening. So when they end up with some symptoms, when we do an echo, we do an ECG, we pick up some abnormalities in the heart. So we end up counseling the couple that they have to terminate pregnancies. So these are the couples where surrogate would be a great help. We've had a lot of Mullerian abnormalities, we call, where there could be uterine abnormalities where the uterus is very small, because the way the ovary is developed is different from the way the uterus is developed. They come from two different structures. You could have a normal ovary, so you can have your own egg. Unfortunately, your ovary is getting developed from a different region. So your uterus is going to be very small. Or we have had situations where there is no uterus at all, or you have a small muscular structure where you cannot conceive at all. Or you have a problem where the vagina itself is not developed. So we call this as Mullerian abnormalities. So they cannot carry the baby in their own womb. So that is when we have to go for surrogacies. A lot of things like this. We do a lot of high-risk pregnancies. Have had patients with renal transplant and they conceive. So we do a lot of high-risk pregnancies. They do go through these consents where they understand what could be the trouble, because we'll have to tell them we have to terminate. So a lot of these things. And sometimes we have terminated because either the kidney is compromising, and then we don't try to help them become pregnant again. That is when we say, look, you really want to have your own progeny, we use your egg, we use your husband's sperm, we form these babies and use a surrogate. So a lot of things like this.
Yeah, so
there are definitely conditions where it is ethically indicated.
And it is always initiated from the doctor's side now.
Yes, it has to be. It has to be.
You identify the medical condition and then you initiate this.
We have to write to the magistrate. We have to write why this is needed, and only then go ahead. So no fancy reasons.
So they can no longer come and say, I want to surrogate.
Yeah, I don't want to take a career break, and this is why I want to.
That's not going to work.
It's not going to work.
Thank you so much for talking to me about fertility issues. We did cover some aspects of it. There are still a lot more, of course.
Definitely. Thank you for this opportunity. It was lovely chatting with you.